Yes, sir. We are live.
Yeah. Should I start?
Yes, I will be starting. I will share the screen and I will start.
Okay.
Good evening to one and all. I am Arpita from the IGCP group, and I welcome you all to yet another very important topic of discussion today, which is an innovative of all port approach for TEP repair of inguinal hernia 555 Manish technique. 1 minute, sir. The voice is echoing. Today we have with us Dr. Manish Kumar Gupta sir. He's MBBS, DNB, FIAGS, FALS, MNA, MN, Vice Chairman and Senior Consultant, Department of Laparoscopic and General Surgery at Sir Gangaram Hospital, Delhi. With this introduction, sir, I would now request you to please start with the topic for today. Over to you, sir.
Thank you, Arpita and Sukanya, for arranging everything for this webinar. So today I'll be talking about my innovative technique for doing TEP repair of inguinal hernia by all 5 mm ports. So as we all know that inguinal hernia repair can be done by open technique as well as laparoscopic repair. It can be done by trans-abdominal pre-peritoneal repair and by a totally extraperitoneal repair. Can you change the slide? Please change the slide. So TEP repair basically has its own steep learning curve, as we have to go in between the pre-peritoneal space, in between the peritoneum and in between the muscle layer. So next slide, please.
Sir, 1 minute, please. There's some.
अरे अभी क्या?
Sorry, sir. Sorry, I'm sharing it again.
I'm not able to change the PPTs actually.
So you let me know. I will be changing them.
Hmm.
Yes, sir. Please continue.
Okay. So we have to go in between the two layers, in between the peritoneum and the muscle layer. And basically there is no space, you have to create a space. So that's why there is a steep learning curve for doing a TEP repair. Next slide. So in the current TEP technique, we use a 12 mm Hassan trocar and we make two 5 mm ports. And this Hassan trocar has got a cone basically, and it's a wide cone. And you have to put this cone inside the skin and the subcutaneous fat. And there is always a dependence over this Hassan trocar to create the preperitoneal space. And right now, this is the only technique known among the laparoscopic surgeons. But nowadays, a few surgeons are putting 12 mm trocar directly into the preperitoneal space. Next slide, please. So the question arises that why do we need a large infraumbilical incision? Because we have to make approximately 1.5 centimeter incision below the belly button. And basically it's because we want to see the anterior rectus sheath and to make an incision to access the preperitoneal space. And we also want to fix the Hassan trocar, so we have to take two anchoring sutures, and that's why we have to make a large incision below the belly button. And the Hassan trocar has got the wide bore cone. So to fix it, you need a bigger incision. And obviously, to insert a mesh, you need a 10 trocar, Hassan trocar, and that's why you need a larger incision below the belly button. Next slide. So there are 6 surgical steps which are used for the risk reduction strategy to improve the clinical outcomes. And for the TEP repair, these 6 steps are basically placement of first trocar, placement of working trocar, dissection of preparietal space, dissection of hernial sac, mesh placement, and closure. So why there are so much emphasis of putting a placement of first trocar and the second trocar? I think there is no laparoscopic surgery in which so much of emphasis is given on these placement of trocars. It's just because, next slide please, because during the insertion of Hassan trocar, in the preparietal space can be inadvertently breached along the peritoneum, which can result in pneumoperitoneum. And this pneumoperitoneum minimizes the operative space and making the further dissection difficult. So putting the trocars in the right space is very crucial in doing a TEP repair, because once the pneumoperitoneum is created, then you won't be able to perform the surgery well. Next slide. So, what are the shortcomings of the current practices? The shortcomings are basically, there are a few shortcomings which come into my mind. That first of all, that we are dependent on a large bore Hassan trocar, and the insertion of Hassan trocar is basically a relatively blind step. You can injure the peritoneum beneath the posterior rectus sheath, and once the peritoneum is injured, then it creates the pneumoperitoneum and it minimizes the space. So this is the biggest shortcoming of the current practice, that putting a Hassan trocar is almost a relatively blind procedure. Only the insertion is under vision. The rest of the insertion up to the peripetal space is almost blind. Next slide, please. The other shortcomings are that the cone leaves a bigger defect in the anterior rectus sheath, and that needs to be repaired at the end of the surgery by the use of a Weichel suture. And similarly, you have to put a Weichel suture in the subcutaneous fat, which will lead to some sort of induration, pain. And once the incision is large, then there are always chances of surgical site infection. And nobody wants a large, a big scar over there, whether it's male or female. Everyone wants a smaller incision. So it's cosmetically unacceptable, basically. Next slide, please. So this is a Hassan trocar, and you can see that the cone of the Hassan trocar is almost like 3 centimeter in size. Even you make a 1 or 1.5 centimeter incision below the belly button, but once you fix this cone, the incision becomes almost 3 centimeter size. So once you close it, the scar becomes 3 centimeter below the belly button, and nobody wants this much big scar and induration or pain after surgery over there. Next slide, please. So is there a way out? Can we really need a 12 millimeter trocar for TEP repair? This is the first question. The second is, can we insert first trocar under complete vision so that we don't injure the peritoneum? Can we access preparietal space and insert mesh through 5 millimeter port? That's a big challenge. And can we complete TEP repair by all 5 millimeter ports? And can we make the procedure simpler and cost effective and reproducible to everyone? So there is an answer. Next slide, please. So I have innovated a 555 Manish technique for doing a TEP repair, and I innovate this technique. I do the TEP repair by all 3 5 millimeter ports, and for this I made a retractor, and which plays a very crucial role in putting the trocar into the preparietal space by a 5 millimeter incision only. I have also innovated a technique for putting a mesh of decent size into the preparietal space by a 5 millimeter port only. So it's a very innovative technique. Next slide, please. Next slide, please. So I have presented this technique on various forums. First, I went to 2016 in Boston. I presented there this technique. I went to European Hernia Society conference in Vienna, another European Hernia Society conference in Hamburg. I went to Dubai for presenting this technique, and it was very well accepted over there. Next slide, please. We have also published the details of initial 61 cases in the index journal, and after that, the same journal has got the video publication also in their the journal. Next slide, please. This technique is also available. The video is also available on the SAGE's website, which we all know that it's an apex body for laparoscopic surgery. Next slide, please. Next slide, please. Anyone can go and check over there. It's available over the SAGE's website. Next slide, please. So initially, I used to make this retractor. It plays a very crucial role in this surgery. Initially, I used to make this retractor with the help of a 2 ml syringe, but later I made it with a alloy. And this retractor, next slide please, has got patent in 2024. These are the initial sketches which I shared with my engineer, and he made this retractor finally. Next slide please. Next slide. So this retractor got patent in 2024, and it took around 4-5 years because I submitted the papers in the pre-COVID time, and it took around 4 or 5 years to complete this patent because of the COVID, and there was no work done at that time over there. Next slide, please. So I used normal 3-5 millimeter trocars along with normal laparoscopic instruments and the retractor, which I gave the name Manish retractor. Next slide, please. Next slide. So this is the difference in the Hassan trocar technique and the 555 Manish technique, in which I only put 5 millimeter trocar into the pre-palatal space rather than a bigger incision for the Hassan trocar. Next slide. So as I told you that the Hassan trocar technique, only the insertion is under vision, the rest of the insertion is blind, while in my technique one can see the whole of the tract, one can see the anterior rectus sheath, the slitted anterior rectus sheath, and then can see the rectus muscle fiber and the posterior rectus sheath and the arcuate ligament. Everything is visible once you reach the pre-palatal space. Next slide. I have also innovated a technique which I call a tail pull technique, in which I put a thread after rolling the mesh to a thinnest possible thickness and put a approximately 15 centimeter thread on one of its end and then pull it inside the 5 millimeter trocar. That I will tell you in my video. Next slide. Please play this video. It's a video, please play it. So these are the normal instruments like Maryland, grasper, scissor, suction, along with 3-5 millimeter trocars, which are visiports, and my retractor. So what this retractor does basically, it has got these cylindrical limbs, and it can open through a hinge joint. And through this retractor, a 5 millimeter trocar can be easily introduced, and it can be taken out after opening it without taking out the trocar from the body. So it snugly fits the trocar, and you can open it and take it out. So I'll just show you how I place it. So after making a 5 millimeter incision below the umbilicus, I deepen the incision with the help of 11 number blade and then put the retractor inside. And what is the function of this retractor? Basically, it retracts the fat outwards and gives a very clear vision of anterior rectus sheath. You can see the glistening anterior rectus sheath below, and you can make suction over there, take out the remaining fat and blood, and you can have a very good view of anterior rectus sheath. So here you can see the glistening white anterior rectus sheath, and you make a 5 millimeter incision into the anterior rectus sheath. Once you make the 5 millimeter incision, you can see the longitudinally running rectus muscle fibers. So here there is a slit in the anterior rectus sheath, and below darker fibers are rectus muscle fibers. So after loading the 5 millimeter trocar to the telescope, we introduce this telescope inside through the slit in the anterior rectus sheath, and that gives a very clear view of each and everything up to the peripatral space. So once we go inside, we can see the upper and the lower lip of the, this is the upper and the lower lip of the slitted anterior rectus sheath. And as you go forward, you can see the rectus muscle fibers, and after further entering, you can see the posterior rectus sheath. That white layer is the posterior rectus sheath, and then there's an arcuate layer ligament beyond which the posterior rectus sheath is deficient. And here you enter into the peripatral space. It hardly takes 30 to 45 seconds to reach the peripatral space after making an incision. While in Hassan trocar technique, it takes approximately 8 to 10 minutes in putting the Hassan trocar and reaching up to the peripatral space. So it saves time, approximately 8 to 10 minutes of time is saved. And once this is done, then we put the CO2, and then we take out the retractor without leaving the trocar. So you don't leave the track. So this is the beauty of this retractor, that retractor can be taken off without taking out the trocar. And then you go inside, then you make two other working ports. I normally do TEP repair with the lateral ports, though this is not the part of this innovative technique. You can make midline ports also, but I initially do some of the blunt dissection in the loose areolar tissue, and then reach up to the anterior abdominal wall, where I make two more working ports, and after this I started doing dissection. So we are seeing this on the left side where there is no hernia. We always see on the contralateral side, and this patient was having indirect inguinal hernia on the right side. The hernial sac is now being dissected from the cord structures, and after the complete dissection, we put the mesh. So the cord structures are being taken off from the hernial sac, and after complete paratalization, we put a mesh inside through the 5 millimeter port. So here I am showing how a 15 into 15 centimeter lightweight or a medium weight mesh can be easily pulled inside from the 5 millimeter trocar. So I put 15 centimeter of the thread on one of its end after rolling it to a minimal possible thickness, and then put the thread inside and then pull it in. So what happens when we put the mesh inside through a 10 millimeter trocar, that our instrument and the mesh both are going inside simultaneously, while in this technique only the mesh is going through the lumen of the trocar and not the instrument. So I come from the other port and then pull the thread inside along with the mesh. So with the 5 millimeter of with the 5 millimeter trocar, you can easily pull the mesh inside. So this is the beauty of this technique. I showed you 15 into 15 centimeter mesh, but here a 12 into 15 centimeter mesh can be easily pulled inside. There's no problem at all. So once the mesh is inside, so here you can see, once the mesh is inside, you can unroll it and then fix it with the help of tacker. Because I make lateral ports, so I have the advantage of putting a tacker in the midline also, along with the, and there are very minimal scar over there with the 5 millimeter incisions. Can you change the slide, please? So our experience is of 653 consecutive cases operated by this technique, and out of these 653 cases, in 641 cases we were successfully able to do the surgery with TEP repair, and because of some other reasons we have to convert the patient to TAPP repair. So in this 641 patients, we have done 923 groin hernias because some of the patients have bilateral hernias. The male to female ratio was 629 is to 12. 12 female patients we operated, and the mean age was 23 to 82 years. Please change the slide. So there were 999 inguinal hernias, in which indirect were 412 and direct were 507. I operated 3 femoral hernias by this technique, 1 obturator hernia, and 15 sliding indirect inguinal hernias by this technique. Next slide, please. There were few cases in which there were contralateral repairs already been done earlier in 18 cases. And in all those cases, we were able to operate by this technique successfully. And there were one patient who had a bilateral orchidopexy. There were one patient who had a recurrent inguinal hernia after enterocutaneous fistula, because the patient had mesh infection and developed enterocutaneous fistula. So in all these complex cases, we were able to perform surgery by our technique. Next slide, please. So average time of putting the first port placement is around 45 seconds, which is far less than the Hassan-Brocard technique. And we experienced 40 in pneumoperitoneum in 43 cases, but that was not in the initial trocar placement. It was during the surgery at different stages. And in all cases, we were able to perform the surgery except in 12 cases in which we have to convert into TAPP repair. And there was no deviation from surgical principles of the standard TEP repair in terms of dissection of the sac and putting a mesh over there. Next slide. We did a randomized control study also, and we have a very encouraging results by our technique. The post-op pain was significantly less. The duration of entering to the preparietal space was significantly less. The infraumbilical port site induration was less. Cosmetic score was pretty good in such patients because they have a very small scar. So all these results were very encouraging to us, and there was no incidence of any surgical site infection or recurrence of any incisional hernia. Next slide. And there were very small scars below the belly button, almost negligible. After 4-5 years, nobody able to find out from where the surgery was done. Next slide, please. So I will like to conclude that TEP repair by 555 Manish technique is a simpler, reproducible, less morbid, time-saving, cost-effective, and is having a better cosmetic outcome. A simple Manish retractor plays a very key role in putting a 5 millimeter trocar into the preparietal space, and above all, that this technique follows all the principles of TEP repair. Thank you. Next slide.
Thank you, sir. Thank you so much. That was an excellent presentation, I would say. In a short time, like the way you have explained through videos and photos, that was really like those who have attended the session are very sure that they have understood the topic well. So,
Thank you.
sir, without doing further delay, yes, sir, I would like to take a few questions that have come from the audience.
Yeah, sure.
Sir, first question is what activities or habit typically make the bulge or pain of a groin hernia worse?
So, inguinal hernia, whenever there is an increased intra-abdominal pressure, that causes the abdominal content to come out. So, whenever you cough a lot, whenever there are a lot of sneezing, whenever you pull the weight, do strenuous exercises, constipation, urinary difficulty, prostate problems, all these causes hernia to bulge out more. So, patient should refrain of doing any strenuous activity or lifting heavy weights. so that the contents should not come out.
Right, sir. Thank you so much. Let me see the next question. Sir, what are the most common sign and symptoms when a patient comes to us? We can see in a groin hernia.
Okay, so the first symptom, basically patient will say whenever he stands up or walks, then he will see a swelling over the pocket area. Okay, and whenever he pushes this swelling inside, it will go inside, or whenever he lies down, it will go inside. So this is the initial, very initial symptoms. And also some patients experience some pain over there. So whenever they start coughing, the bulge comes out more, and whenever they presses it or lie down, then the hernial swelling goes inside. So these are the very initial symptoms. The rest of the symptoms are of the complications once the uh, omentum or the intestine go as stuck over there, then it becomes irreducible, and sometimes the patient will also have intestinal obstruction or strangulation because of these complications.
One question has come, though the time doesn't permit, but I need to take this, sir. He is asking, sir, what has inspired you to develop the 555 Manish technique?
So actually, uh, initially we were always able to do all the laparoscopic surgery by 5 millimeter ports. Okay, because we have got 5 meter telescopes also, 10 meter telescopes also, and we were able to perform all surgeries by 5 millimeter incisions. So that one thing came into my mind, that why we should not do this surgery by 5 millimeter telescopes. Why we always use this Hassan trocar. So there was some challenges over there, which I narrated in my slide. That how do we put a mesh inside, how we fix it. So those were the things which were in my mind. And then once I thought, let me try and put a 5 millimeter telescope into the preparatory space, and then I'll see that how to put a mesh inside. And there was one resident who was with me. His name is Dr. Johil, and I always give this credit to him. That he told me that, sir, आप start कीजिए, and then we will see. We will otherwise we will convert the 5 millimeter telescope to 10 millimeter to put a mesh inside. And in between, during surgery only, I thought, let me pull this mesh inside with putting a thread over there, and it worked. At the same time, it worked. So that was the initial story.
Right, sir. So, with your permission, one last question.
Yeah, sure.
Sir, what are the key tips that you would suggest for the surgeons who are planning to adopt this technique, sir? Any 3 or 4 points?
Okay, so that I say that it's easier to put a 5 millimeter telescope under full vision in the preparatory space. So you just need a small training sort of a thing, because every laparoscopic surgeon is well versed with the handling of the instruments. So and someone who is doing TEP repair already knows how to do a dissection inside the preparatory space. So it's just a matter of putting a 5 millimeter telescope in the preparatory space, and I don't think that it does need too much of training as such. So I think everyone can start it. It's easy. I don't think it's a tough thing.
Thank you. Thank you so much, sir. With that, we would like to conclude the session for today. But before that, I would like to thank you for your insightful presentation, sir. Your expert guidance, practical tips, and valuable clinical insights have provided us with a very deeper understanding of this very innovative approach and its potential benefit in enhancing surgical precision and patient outcomes. We sincerely appreciate you for taking time to share your valuable experience with us, sir, and it has been a truly enriching experience for all of us. Thank you, sir. Thank you once again. And thanks to all our audience for joining, for putting your questions and making it a very engaging one. So thank you, everyone. With that, I would like to conclude our
Thank,
session.